Good morning, everyone. My name's Dr. Luke Jelen. There we go. And it's a real pleasure to be involved in this symposium. Well, once we get that sorted. Sorry. Let me try this again. That's fine there. It's fine there. I think this is the main one. I can see here, as long as it's okay there. Okay, there. Okay, after all these technical issues, hopefully we can proceed. So good morning, everyone. My name's Dr. Luke Jelen, and it's a real pleasure to be involved in this symposium on new treatment modalities in psychopharmacology. Big thank you to the organizers for their invitation and for the opportunity for me to talk about the role of the opioid system in depression today. A few declarations here, employed by King's College London and currently funded by UK Medical Research Council Clinical Research Training Fellowship and undertaking a PhD on investigating glutamate and opioid mechanisms of antidepressant response to ketamine. So in today's talk, I aim to provide a brief introduction and overview of the endogenous opioid system. I'll touch on some of the preclinical evidence highlighting a role for the opioid system in depression. Next, I'll share highlights from some experimental medicine studies in humans that further support a role for the opioid system in depression. In the later half of the talk, I'll provide an overview of findings from some of the clinical studies of opioidergic agents in depression, before finally finishing with a discussion surrounding the somewhat contentious topic of the role of the opioid system in ketamine's antidepressant effects. So first, a bit of background. Opium is an extract of the exudate derived from the seed pods of the opium poppy Papaver somniferum, and it contains high concentrations of the prototypical opiate morphine. The Sumerians of Mesopotamia were the first identified to have cultivated the poppy from the plant around 3400 BC. They named it Hul Gil, or the plant of joy. It eventually spread through the ancient world to every major civilization in Europe and Asia, and was used to treat pain and many other ailments. Homer conveys its effects quite nicely in the Odyssey. In one episode, Telemachus is depressed after failing to find his father Odysseus. But then Helen had a happy thought. Into the bowl in which their wine was mixed, she slipped a drug that had the power of robbing grief and anger of their sting and banishing all painful memories. No one who swallowed this dissolved in their wine could shed a single tear that day. So opium in the form of a tincture was introduced in the treatment of melancholia towards the end of the 19th century by Emil Kraepelin. The so-called opium cure was widely used and noted as a rapidly effective treatment for refractory melancholic depression. Unfortunately, with the unregulated availability of opioid agents and non-medical abuse of diverted supplies resulted in widespread dependence and addiction. With an increase in restrictive legislation surrounding their prescription alongside the advent of non-addictive antidepressant treatments in the 1950s, the use of opioids in depression became obsolete. However, there's now a growing body of evidence that indicates the endogenous opioid system is directly involved in the regulation of mood, leading to a resurgence of interest in targeting this system to alleviate depressive disorders. So the endogenous opioid system is comprised of distinct opioid neuropeptides, including beta endorphin, dynorphins, enkephalins, and associated G-protein coupled receptors. These include 3 classic opioid receptors, the mu, delta, and kappa opioid receptor, and the non-opioid nociceptin orphanin FQ receptor, encoded by the genes shown here, along with their distribution in the brain. The opioid system plays a central role in pain processing and regulates other diverse aspects of physiology, including respiratory, gastrointestinal, endocrine, and immune functions. Now, importantly, this system also regulates responses to stress and modulates aspects of human mood and well-being, providing a rationale to further explore this target in depression research and drug development. So, first of all, evidence from preclinical, genetic, and pharmacological studies have revealed opioid associations with behaviors associated with depression and positive effects of opioidergic drugs in rodent models. Preclinical work highlights distinct functions of the opioid receptor subtypes in regulating mood-related processes, including reward, motivation, and social behaviors. In brief, stimulating the mu and delta opioid receptor improves mood in rodent models acutely, with mu opioid receptors closely related to more reward and dependence. Interestingly, with the kappa opioid receptor system, if stimulated, this has more aversive or pro-depressive effects. Looking at the pharmacological studies from the preclinical work, these suggest antidepressant potential of mu opioid and delta opioid receptor agonists and kappa opioid receptor antagonists. However, it's important to note these are only rodent models, therefore translating the work into humans is a key step. So looking back to humans, the distribution of mu opioid receptors can be quantified in vivo using PET, using the mu opioid receptor selective radiotracer carfentanil. And mu opioid receptors appear to share significant overlap with regions and circuits implicated in emotional processing and regulation. In one interesting PET study in healthy volunteers, the self-induction of a sustained sadness state was associated with reductions in mu opioid receptor-mediated transmission in a region of the rostral anterior cingulate cortex. This is a region implicated in the regulation of mood, cognitive control, and emotional processing. A subsequent study using this same sustained sadness task in major depressive disorder, prior to the initiation of an SSRI, found those that did not respond to SSRI treatment demonstrated increases in mu opioid transmission during the sadness induction. So they saw reduced binding potential, while responders showed a reduction similar to that seen in healthy volunteers in their first study. Finally, a large cross-sectional study found lower mu opioid receptor availability in subclinical depression and anxiety in cortical and subcortical areas, notably the amygdala, hippocampus, ventral striatum, and cingulate cortices. Altogether, supporting this idea of a dysregulated mu opioid receptor availability may be involved in altered mood and depression. Additional PET work has explored the involvement of the mu opioid receptor system in regulating social behaviors in healthy and depressed subjects. In one study measured changes in mu opioid receptor binding during social rejection and social acceptance task conditions. During rejection, major depressive disorder patients did not show significant activation, whereas the healthy controls, showed there on the left, mu-opioid receptor activation was found in the nucleus accumbens, amygdala, and thalamus. These are all structures high in mu-opioid receptor concentration and part of a pathway by which stressors can influence mood and motivation. Therefore, mu-opioid receptor activation in these structures may reduce the negative impact of stressors. During the acceptance condition, only the healthy volunteers showed an increase in social motivation, which was positively correlated with mu-opioid receptor activation in the nucleus accumbens, a region known to be involved in reward. So together, this suggests that abnormal mu-opioid receptor function in depression may hinder emotional recovery from negative social interactions and decrease pleasure derived from positive interactions. So both of these effects together may reinforce depression, trigger relapse, and even contribute to poor treatment outcomes. There's further evidence emerging that opioid modulation may be involved in the antidepressant responses via placebo effects based on reward and reinforcement principles. One nice study found reductions in depressive symptoms after placebo treatment to be associated with increased placebo-induced mu-opioid neurotransmission in a network of regions implicated in emotion and stress regulation, including the subgenual anterior cingulate cortex, nucleus accumbens again, thalamus, and amygdala. Furthermore, when patients subsequently received 10 weeks of open-label treatment with an SSRI, placebo-induced opioid release in the nucleus accumbens was associated with better treatment response. So interestingly, this suggests that mu-opioid receptors are not only involved in the neurobiology of normal and pathological emotional, social, and stress processing, but also potentially in modulating pharmacological and cognitive mechanisms of treatment response. So next, moving on, I want to touch on some of the findings from clinical studies of opioidergic agents in depression. First of all, several studies have evaluated antidepressant effects of the mu-opioid receptor partial agonist, but also kappa-opioid receptor antagonist, buprenorphine, in major depressive disorder. While all these studies had a very small sample size, and only one here included a placebo-controlled condition, antidepressant effects were pretty consistently reported following low doses of sublingual or intranasal buprenorphine, including in patients with treatment-resistant depression. Further work has examined whether buprenorphine may have specific anti-suicidal effects. In a randomized double-blind placebo-controlled trial in patients with severe suicidal ideation, sublingual buprenorphine at a mean dose of 0.44 milligrams per day led to significantly greater reduction in suicidal symptoms than placebo at both 2 weeks and their primary endpoint, which was 4 weeks. Now, although buprenorphine is only a partial mu-opioid receptor agonist with much lower potential for dependence and abuse and misuse than pure agonists like morphine, it still has abuse potential and the drug may be misused. So, although buprenorphine has demonstrated potential beneficial effects, the widespread use of treatments acting as full or partial mu-opioid receptor agonists in depression has been limited by concerns regarding the significant risk of abuse and dependency. To address this, the combination of buprenorphine with a potent mu-opioid receptor antagonist called samidorphan has been investigated to determine whether antidepressant effects may still be achieved through opioid modulation while minimizing the risk for addiction. Now, there was some positive efficacy signal in 2 initial phase 2 studies as an adjunctive treatment in major depressive disorder. However, out of 3 subsequent larger phase 3 studies, only 1 met their pre-specified primary endpoint. And there was a bit of controversy surrounding the kind of endpoint they chose of average difference change from baseline to week 3 to the end of treatment. And the Food and Drug Administration, when they reviewed this evidence, didn't support an application for the use of the buprenorphine-samidorphan combination, raising concerns that substantial evidence of effectiveness had not been demonstrated and still concerns over benefit-risk profile. So moving away from mu to touch on the kappa-opioid receptor system, there's been a double-blind, randomized, controlled proof-of-mechanism trial evaluating aticaprant, a selective kappa-opioid, as a treatment for anhedonia. And this demonstrated in patients specifically recruited with anhedonia, the aticaprant-treated group exhibited significantly increased fMRI ventral striatal activation during reward anticipation in the monetary incentive delay task compared with placebo. Now, the finding that aticaprant directly influences brain function implicated in hedonic responses, and that clinical anhedonia scores following aticaprant relative to placebo reduce, measured here with the SHAPS, suggests the potential of kappa-opioid receptor antagonists as an anhedonia therapy that may have therapeutic implications beyond the treatment of major depressive disorder. There has been a large phase 2 RCT designed to explore the efficacy of aticaprant compared to placebo, again when administered as an adjunctive treatment, but we're waiting the results of this study to be published. Now, compared to the limited number of studies investigating the antidepressant effects of kappa-opioid receptor specific antagonists, there's even less work examining the potential of selective delta opioid agonists. Now, one major issue that's limited the development of delta opioid receptor agonists as antidepressant candidates is proconvulsive activity associated with some of these compounds that's been highlighted by preclinical work. There has been one small randomized placebo-controlled pilot study of the compound AZD2327 in patients with anxious depression. However, in this small pilot, there was no significant main drug effect found for either the HAM-A or HAM-D scores. Oh, we were doing so well there. Yep. So further well-powered studies are needed to explore the potential of delta opioid receptor agonist compounds. So next, I wanted to touch a bit on the dissociative anesthetic ketamine that James had introduced. So ketamine is primarily described as an uncompetitive NMDA receptor antagonist, but also interacts with a range of other receptors, including GABA, dopamine, serotonin, cholinergic, and opioid. Focusing on potential interactions with the opioid system, ketamine has micromolar affinity for mu and kappa opioid receptors. Ketamine produces opioid receptor-dependent analgesia at higher doses. It also potentiates opioid analgesic effects. At much higher doses, produces mu opioid receptor-dependent respiratory depression. However, less is known about the role of the opioid system for the lower doses used for the antidepressant effects. There was a key study by Williams et al. From Alan Schatzberg's group in 12 subjects with treatment-resistant depression. And they found that pre-treatment with naltrexone, an opioid receptor antagonist, significantly attenuated antidepressant and anti-suicidal effects of ketamine. This was a significant suggesting opioid activation may be necessary for the rapid-acting antidepressant effects of ketamine, and received a large amount of media coverage, with some headlines unhelpfully suggesting ketamine as an opioid. However, this was a very small pilot study, and other pilot work in individuals with comorbid alcohol use disorder has failed to replicate this effect. Larger clinical replication studies are really needed to clarify the role of the opioid system in both the acute and post-acute effects of ketamine and S-ketamine. Considering differences between ketamines and enantiomers, it's known that S-ketamine has higher affinity and potency than R-ketamine at both mu and kappa opioid receptors. There's been some really interesting recent preclinical work from Bonaventura et al. That's shown antidepressant doses of S-ketamine but not R-ketamine induce condition-place preference. And furthermore, S-ketamine increased metabolic activity and dopamine tone in medial prefrontal cortex regions of rats in an opioid receptor-dependent manner. Obviously, further clinical work in clinical populations is needed to compare opioid interactions for ketamines and enantiomers. But based on this finding, the authors suggest racemic ketamines abuse liability may be primarily driven by the effects of its S-enantiomer. Now, there are some clinical trials of R-ketamine in depression underway, and if these demonstrate efficacy, it may turn out that R-ketamine could prove to have a more favorable benefit-risk treatment profile over S-ketamine, especially for those patients with comorbid substance use disorders. Before I finish, I wanted to briefly introduce the experimental medicine study I'm leading for my PhD. Briefly, this is designed as a replication of the naltrexone ketamine study I described earlier. However, we're aiming for a larger sample size and also be focusing on neuroimaging mechanisms. The study is a randomized double-blind crossover design with 2 treatment conditions, oral placebo or oral naltrexone, preceding ketamine infusion, but we actually administer the ketamine infusion within the MRI scan environment to look at acute imaging changes. The overall aim is to determine the acute effects of ketamine on brain glutamate levels, cerebral blood flow, and also functional connectivity in patients with depression, and establish if pre-treatment with naltrexone attenuates any of these effects. Here's an overview of the imaging protocol we're using. Aside from structural scans, we're collecting arterial spin labeling at a pre-ketamine baseline and also at the end of the infusion. We're looking at resting state, fMRI, again at baseline and immediately repeated just at the end of the infusion. We're also using a technique called functional magnetic resonance spectroscopy, where we acquire a long collection of spectroscopy scans, and that's hopefully going to allow us to get a readout of changes in glutamate dynamics through the ketamine infusion. And we'll also be able to investigate whether any alterations in these imaging measures may be linked to changes in depressive symptoms and subjective drug effect measures. Sorry that we're nearing the end of recruitment for this study. Very sorry I can't share any findings with you yet today, but hopeful this work will reveal more about the role of the opioid system in ketamine's antidepressant effects. So just to conclude on what we've covered today, opioid receptor subtypes regulate mood-related processes, including reward, motivation, and social behaviors. Experimental medicine studies have implicated the opioid system in emotional processing, and this system may be dysregulated in depression. Clinical studies have suggested mu opioid receptor and kappa opioid receptor agonist-antagonist combinations to show some early indications of antidepressant efficacy while minimizing the risk of abuse liability. Delta opioid receptor specific agonists and kappa opioid receptor selective antagonists are novel targets that may be viable options in the treatment of major depressive disorder. And finally, further work is really needed to understand more about the role of the opioid system in modulating the effects of existing treatments we are using, such as ketamine. And as I said, hopefully I'll be able to share some more data on this soon.
Thank you very much.